Mother and Child Hospital at Nerul, and she's past president of Navi Mumbai Obs and Gynae Society. And today's lecture would be taken up by Dr. Deepak. He is an MB Grant Government Medical College alumni who did his MD from PIMS Loni, super specialty from Aster Medicity Kochi, and he's also an MRCP holder with fellowships in endoscopic ultrasound, advanced endoscopy, along with magnifying endoscopy, third stage space endoscopy. He's presently attached to Kokilaben, Dhirubhai Ambani Hospital, Navi Mumbai, apart from Alpha 1 at Kharwar. Our second expert today would be Dr. Amey. He is consultant gastroenterology hepatologist at Apollo Hospitals, Navi Mumbai, and with his fellowship in clinical and transplant hepatology. Our third expert would be Dr. Ashwati. She is consultant nephrologist at Apollo Hospital, Navi Mumbai, and alumni of LTMMC and St. GS Medical College. She has special interest in obstetric nephrology, resistant hypertension, lupus nephritis, and transplantation. So going ahead, we'll start with the first lecture by Dr. Deepak on drug-induced hepatitis in pregnancy. So
thank you.
Deepak, I'll be giving over to
you. So I will be sharing my screen. Just
yes.
Just 1 minute. I have to screen.
Yeah, at the below you see the option of arrow mark of share screen.
Yeah, just 1 minute. Just that's I'm doing Microsoft PowerPoint share. I have to give it to. Can you see my PowerPoint presentation now?
Yes,
hello.
We can see.
Yes, sir, we can see.
So I will be starting my topics. Sorry for listening. So the topic was given to me by the society is drug-induced hepatitis in pregnancy. I like the concept of discussing the liver and pregnancy. So it's I think it's a second session. So for this topic, I have some my personal opinion that the topic what is given is a drug-induced hepatitis in pregnancy, but it should be a liver injury in pregnancy. That is what we discuss as DILI in pregnancy. So this is a scientific terminology what we use in our community. So why liver injury? So liver injury, as you can see here, the clinico-pathological phenotypes of liver injury are different. There are multiple things what we include as a liver injury. It includes hepatitis as a part. As you can see here, the acute hepatitis, cholestatic mixed pattern of hepatitis that we see commonly. But apart from that, there is a hepatic steatosis, sinusoidal obstruction syndrome, acute fatty liver, granulomatous hepatitis, secondary sclerosing cholangitis, ileosis hepatitis. These are also liver injuries. So usually what we consider liver injury is a broader term, and it includes one of the type is acute hepatitis and cholestatic mixed hepatitis. So in a pregnancy, what the different types of liver injuries, which varies according to a distribution, according to time in the pregnancy, in a first, second, and third trimester. So as you can see, the drug-induced liver injury also is included in this thing. That is mostly included in the first, second, third. The pre-pregnancy drugs usually we are not seeing in a practice that they carry on the liver toxicity in the pregnancy. So it is in the first, second, and third. The distribution is very wide. And that's why the difficulty and diagnosing in a DILI in pregnancy is that we cannot differentiate it between pre-existing or new onset liver disease. So, and DILI can present certainly with overt hepatitis. So that is one big problem, that we have to distinguish that it is because of the drug-induced liver injury or any other pathologies involved. Uh, Many cases they're detected first via the liver biochemistries. In a routine checkup or something, we have a doubt, decreased appetite, we do the level and we found out there is a mild elevation in AST, ALT, and then that will be a suspicion for drug-induced liver injury. So for this type of injuries, we need to keep a keen eye. So always in a liver pregnancy, we think about the AFLP and acute fatty liver of pregnancy, acute liver failure secondary to acute viral hepatitis. Those are the common things, but this is also a concerning factor these days now. So what is the risk factors? So in pregnancy, the comorbidities like malnutrition, obesity, diabetes, pre-existing liver disease is the risk factors. Drug-induced drug, which drug is used, the dose, the polypharmacy, other part like infection, intestinal microbiome, alcohol, smoking, pollutants, socioeconomic status also determines the drug-induced liver injury in pregnancy. Why I am telling you this thing? Because the drugs which are considered safe for use in pregnancy are also known to cause the idiosyncratic drug-induced liver injury. So what is the idiosyncratic drug induced, that we will see in the next slide. So that's why I'm just telling you high index of suspicion should be pertaining for the early detection. So types of drug-induced liver injury in pregnancy. There are three types. First is direct. So what is a direct injury? That is a dose-dependent, predictable, and it is a leading cause of acute liver failure in pregnancy. So this type of injury, what we are very sensitive of, that we see the liver abnormality, liver enzyme abnormality, we see what are the drugs given. So that is a direct relation with this thing. But there are somewhat called as an idiosyncratic injury, which is unpredictable, rare, and the drug can be, the exposure of the drug can be in the last 3 to 6 months also. So that's why idiosyncratic injuries might be missed sometime, and the diagnosis will be difficult in this case. And the response of the drug and the injury is very, we cannot determine it how it predicts. So even a safe pregnancy drugs like paracetamol, methyl-dopa, nevirapine, and propylthiouracil also cause the idiosyncratic drug injuries. So indirect injuries like previously present pre-existing liver disease and other injury on their disease is called indirect injury. So what is the first step in diagnosis drug-induced liver injury? So what we call is a liver biochemistry, not a liver function test, because the real liver function tests are albumin, INR, and bilirubin, and those things. But what AST, ALT is not a liver functions. These are the liver enzymes. So those determine the type of injury what we are looking at. That's why upon looking at the AST, ALT, and alkaline phosphatase level, we can differentiate the injury into three types. That is a hepatocellular, cholestatic, and mixed. What is a hepatocellular? The primary injury is at the hepatocyte level. What is a cholestatic injury? That is a primary injury is a gallbladder or biliary tract or any intrahepatic biliary tract ductal site. And there are sometimes mixed. So both components are involved. So how to differentiate between the two? So there is a clear-cut formula what we practice. That is a R factor. That hepatocellular injuries R factor is more than 5. The formula is you can just remember it. ALT is by ALT upper normal limit. Then alkaline phosphate by upper. But the problem with this formula is that in a pregnancy in the third trimester, alkaline phosphate level increases because placenta secretes the alkaline phosphatase. So in that case, sometimes we need to correlate it with the GGT levels. So how much GGT is raised, that will tell us what type of injury it is. If GGT levels are high, then that might be a cholestatic type of injury. So you should be careful in calculating R factor in the pregnancy. Most of the cholestatic injuries we might miss, or we may overestimate that it is a cholestatic injury because alkaline phosphate is raised in third trimester. So in simple terms, the direct injury is a hepatocellular type most of the time. Idiosyncratic is a cholestatic type, and indirect is mixed type. So this is how the normal AST, ALT, and that I think last program you have discussed with the all normal physiological changes in pregnancy. So these are the normal values of AST, ALT, alkaline phosphate, bilirubin, and albumin in the pregnancy. In the third trimester, you can see the alkaline phosphatase level usually increase from normal 130 to maximum is a 418. So that is the difficulty in assessing the which type of injury is going on. but still the GGT and fine nucleotides, these two markers are helpful for us to see the origin of the liver injury. And this question is very relevant, that does pregnancy cause more severe drug-induced liver injury? The yes. So this is a US drug-induced liver injury network experience. In that they have actually examined 2,600 cases. In that they have observed that the same illness in the pregnancy, the higher median ALT and AST is observed than non-pregnant cohort. So pregnancy is known to exacerbate the disease because of the inflammatory response is high to hepatotoxins, and detection is delayed due to the overlap symptoms of the normal pregnancy. That's nausea, vomiting, decreased appetite, can be misdiagnosed as a other disease related to pregnancy than the drug-induced liver injury. So you can see in this flow chart, this is a standard protocol what we are following in the liver test in pregnancy. So in both cholestatic pattern of liver injury, the drug-induced liver injury is included, and hepatocellular pattern also, drug-induced liver injury is included. So so both side we need to suspect the drug-induced liver injury. That's what I need to convey here. This is the first step. So we need to differentiate between hepatocellular, cholestatic, and mixed type. Then second step is the imaging. So sonography is very safe in all trimester. Apart from that, MRCP also with some if there is a confusion, we usually take the help of MRCP. So MRCP is a non-contrast MRI. It usually tracks down the bile tract, gallbladder, and pancreatic duct. You can see in the left side. So this type of images we can see. So we can see any obstruction of biliary tract outside the liver and inside the liver also. So these are the safe imaging modalities in the pregnancy. This is our case. So you can see here the gallbladder mass we are seeing. This is a pregnant woman of I think second trimester, and we have diagnosed the gallbladder mass here with this imaging. Third step, this we usually avoid, but if it is needed, liver biopsy, we usually do in a second trimester. I have not done one single liver biopsy in a pregnant woman because it is a risky affair in pregnancy. So we avoid this type of invasive procedure in the pregnancy to diagnose the liver disease. So with this all the information in our hand, if liver biopsy we have to do or not, we have to see how is the risk and benefit. The situation favoring us, sometimes a biopsy is a drug-induced liver injury with multiple agents involved, and we need to prove which drug is involved, and we need to stop that. So that's why sometimes in a rare situation it is used in our field. I have not seen the single liver biopsy in a pregnancy. I think Dr. Amay might have experience in that, but we usually avoid liver biopsy in a pregnancy. This is a RUCAM score. So how to go ahead? Now we know what are the investigation, which type of liver injury it is, and is it related to drug or not. So this is a RUCAM score that what we clinically use. So here we usually see the time of onset of beginning of drug and herb, because we usually see the drug-induced liver injury with the herb-induced liver injury also. Herb and CAM, there is a complementary alternative medicine. So the timeline is 5 to 90, more than 90. So the points are given accordingly. Course of alkaline phosphatase, because most of the liver injuries which are drug induced are present like a cholestatic pattern. That's why alkaline phosphatase also included here. Risk factor like alcohol, pregnancy, age, concomitant use of drug, which are known to cause liver injury. The points are given to that. The negative pointers also are there because we need to rule out some diseases. In that, the viral hepatitis, alcoholism, acute recent hypotension history, and underlying disease like sepsis, metastasis, malignancy, autoimmune hepatitis, known case of liver disease earlier, chronic hepatitis B and C, and infection if it is proven by the PCR and cultures. So these are the score what we calculate, and the significant score we usually consider more than 6. That is significant score in RUCAM. And then the association of drug is can be contributed to the liver injury. Then how to see what drug causes the liver injury? So these are the online sites or resources where we can use the resources, then we can filter out all the drugs what the patient is using, and those are high risk liver injury potential or not. So you can see this US Food and Drugs. It is very simple to use. it usually gives the information like most daily concern, no daily concern, less daily concern. So you can just filter out your drug polypharmacy and just find out which drugs can be causing the drug-induced liver injury in your patient. So, what are the common drugs causing delay? I cannot cover all the drugs, but what are the common causes, drugs causing the delay in pregnancy? So, these are the common drugs. All, I think it's coincidentally that all are starting from A. The alpha methyl dopa, antitubercular therapy drugs, isoniazid, rifampicin, pyrazinamide, acetaminophen, paracetamol. That is the most common drug in the US and Western countries. Antithyroid drugs like propylthiouracil, antibiotics like amoxicillin and nitrofurantoin. CAM is complementary and alternative medicine that includes the Ayurvedic, homeopathic, and Siddha medicines, Unani medicines also. So first I will start with alpha methyl dopa. So it is an alpha 2 adrenergic agonist, as you already know it. This is the first line as for hypertension in pregnancy. According to the DILI network registry, it is a 56.3% of pregnancies or DILI is associated with alpha methyl dopa. The type of injury is hepatocellular and idiosyncratic, and it mimic the autoimmune hepatitis like feature. So ANA will be positive, some markers will be positive, and that will mimic the autoimmune hepatitis. So we will keep a watch on this drug when we see this kind of injuries. And it's a fetal safe but maternal hazardous drug. So ACOG and Society for Maternal Fetal Medicine, actually they less favor this drug, and they usually promote labetalol, nifedipine, hadlazine to protect from the liver injuries. Paracetamol is, we already know that it crosses the placenta and there is a direct dose dependent injury. It is not only in pregnancy, but non-pregnant females or non-pregnant person also. Paracetamol is a most common drug injury in Western countries. So overdose can injure the maternal fetal hepatocytes. The severe cases, it can lead to acute liver failure requiring transplantation also. Clinical presentation is pain, vomiting, hepatotoxicity, like jaundice, and that is main features. And it will be vague in the pregnancy. We have to dig up the patient is taking paracetamol or not by herself. So maximum dose is eligible is 3 gram in the pregnancy. Toxicity threshold is more than 7.5 gram single dose or more than 12 gram in 24 hours. The antidote is N-acetylcysteine, as we know. Antithyroid drugs in pregnancy, the propylthiouracil. So it has a black box warning for severe idiosyncratic liver injury and acute liver failure in pregnancy. But it is still, despite its toxicity, liver toxicity, it is a drug of choice in the first trimester because there is no option. So other drug is a methimazole, it's a thiamide. So that is associated with embryopathies like aplasia cutis, choanal atresia during organogenesis. So that's why this propylthiouracil is most commonly used antithyroid drug in the first trimester, and it has to be shifted to methimazole after in the second and third trimester. In the antiretroviral nevirapine, I don't think so. We are using it now here in India as a first-line therapy, but it is known to cause this thing. And the predictor factors is high pre-treatment CD4 counts because the immunity should be good to cause a liver injury. Hepatitis C co-infection, prophylaxis more than 2 weeks. In this, atazanavir also is causing the liver injury. So antitubercular drugs, as we know, it is the most common cause in India, the drug-induced liver injury. So isoniazid is a main culprit. Rifampicin and pyrazinamide are also known to cause the liver injuries. So and isoniazid is the most common, is a high mortality without means isoniazid in the young adults also we are seeing it is a very severe patient with causing acute liver failure, which requiring a liver transplant also sometime. Anti-epileptic drugs. So usually these two drugs are considered safe as anti-epileptic drugs in pregnancy. So lamotrigine is rarely cause the DILI, but it should be compared to traditional drugs, and it is still hepatotoxic in rare cases. So we usually shift to the levetiracetam if we see this drug in prescription. Complementary and alternative, this problem we identified recently, I think in India, that Giloy poisoning, herbomineral formulation contain lead and mercury, and this Cavasurapudinir. These are Siddha medicine. So all these medicine causes the liver injury. The giloy is mostly reported, I think, in pregnancy in India and outside of the India. So autoimmune like hepatitis is seen in giloy poisoning. So these many complementary and alternative medicines we are practicing. All are causing the liver injury. You can see the green tea extract. So if patient is uh, taking the green tea daily or something, just tell them to avoid. Too much turmeric also cause the liver injuries, and giloy, as we know. Ashwagandha is well known, but I don't know the pregnant women are using or not. But these are the Herbalife products. These are also commonly used. So keep a watch on this list. Always ask your patient if they are taking any herbal product, because they will not mention any herbal product in their drug history, because they think it is a natural product and it is not major value in their history. So treatment in acetylcysteine is in paracetamol poisoning and non-paracetamol, both poisoning we usually use in practice. The non-paracetamol poisoning in acetylcysteine use is still ongoing clinical trials, but it is very safe to use in pregnancy. So NAC infusion or NAC drug use in this thing is very common, and we use it in an acute liver failure stage to avoid or to delay the liver transplant or to avoid the liver transplant. The plasmapheresis and transplantation are the ultimate thing, which plasmapheresis is like dialysis. We exchange the plasma multiple times, and that usually used for the bridge the pregnant patient to recovery or transplant. So survival without transplant is increases because of the plasmapheresis also. So this is what is my short topic discussion. Dr. Amay, want to add something?
No, you covered it very well. Actually, it's a very vast topic. You cannot discuss
I know,
everything.
we cannot
Actually,
cover,
in
but
20
I
minutes.
think
I think
But
this is
very
the
well
biggest.
put, and yes, discussed.
The biggest chapter in our textbook is Delhi.
I know, Delhi.
The longest chapter ever.
Yeah, and always we also refer many times that the drug. Our half work is to eliminate the drugs from the prescription. So in pregnancy, I have not seen many cases of Delhi, but I used to change the prescription sometime. Like if there's alpha methyl dopa, I will tell the obs-gynae to change to something else. If the diagnosis is still the other disease like viral hepatitis or something, still I want to use a safe drugs.
Luckily or unluckily, alpha methyl dopa is no more available for us.
I know. So
But
that it is good for
shocking
us
to
now.
know that paracetamol also can cause delay, idiosyncratic reaction.
So not in India. Indian, I don't know, but Western countries are more seeing the paracetamol poisoning. I have not seen the one paracetamol poisoning patient coming with this thing, suicidal consumption of paracetamol, but still they don't feature out this feature because the toxic dose is very high, 7.5 gram.
And it was surprising to see turmeric in the list.
So that is what case report says. I think Dr. Amay has an experience.
I don't know what it's used in medicinal dose, but I think that is used day to day. Turmeric is consumed by each one of us.
Too much of turmeric is not good. I think that used as
excess
a drug.
Quantities.
Excess quantity, I think. The case report has.
Is there any standard thing when to say it is excess and no excess?
There is nothing standardized.
Turmeric just like that, you know.
So in India, common is anti-tubercular drugs. Most common is what we see. Delhi, and second most common is a complementary alternative medications.
Yes.
That is the second most common we see.
Yeah. So
especially ACLF.
ACLF. Giloy and I think the Herbalife product also. Last year I have seen 2-3 cases.
Products.
Slimming products. So they usually consider it as a food, but it is herbal. So we need to ask them about those things also.
Correct.
So check the pharmacy. I think whatever the prescription, correct it, and then diagnose the other disease also. Whatever you are searching for the liver injury for this.
Very good. Very nice.
Thank you, sir. Thank you for giving this detailed information. We as obstetricians should be aware of the drugs causing delay. And now moving on to our case presentation session. So we have an interesting case which would be presented by one of our DNB students here at Apollo, Dr. Aziza. So, Aziza, are you here?
Yes, ma'am. Good
Okay,
afternoon, all. Myself, Dr. Aziza, DNB student in Apollo Hospital. I am presenting a case on acute fatty liver of pregnancy. So the chief complaints, 35-year female, primary gravida at 37 plus 2 weeks of gestation, was referred from an outside hospital with complaints of multiple episodes of vomiting since 3 days, and it was associated with abdominal pain, and there was yellowish discoloration of eyes and urine since 2 days, and she also complained of decreased fetal movements for past 1 day. The patient was referred from outside with a deranged liver and renal function test, and there was a deranged coagulation profile. There was history of polydipsia and polyuria also, and no complaints of bleeding or leaking per vaginum, no history of raised BP or headache or blurring of vision or any other premonitory symptoms, no history of no travel history, no history of fever or rashes, no prior history of any renal issues. So menstrual history, it was regular. LMP was on 14th 3 2025 and EDD was 13/12/2025. Obstetric history, she was primary gravida, spontaneously conceived, uneventful antenatal period. She was not registered in with us. Medical history, she was non-case of hypothyroidism and was on tablet Thyronorm 75 microgram. There was nil surgical history and family history was also not significant. On examination, patient was conscious and oriented, and she was pale. Icterus was present. Pulse rate was on 92 beats per minute, and BP was 134/74 millimeters of mercury, and blood sugars were 57. Temperature was 98.1 degree Fahrenheit, and per abdominal examination, uterus was term, relaxed, cephalic, but FHS was absent, and on PB examination, cervix was soft, posterior, and 1 centimeter dilated. All the following lab reports were sent, and CBC revealed hemoglobin of 14, total counts of 17,820, and platelets were 1.77 lakhs. Bilirubin was 9 milligram per deciliter. Direct and indirect bilirubin 7.5 and 2.47 milligram per deciliter. OTPT was also raised. 315 and 421 unit per liter, and serum albumin was 3.55, GGT was 173, ALP was 658 unit per liter, serum uric acid was 9.9, and serum creatine was 2.48. PTNR was 24.2 and 1.95. Serum electrolytes, sodium and potassium were 139 and 5.4. Urine routine examination revealed 10 to 12 pus cells, RBCs, and 8 to 10 pus cells. No protein, no bacteria. VBG revealed a metabolic acidosis. Ultrasound was done, and which confirmed intrauterine fetal demise with cephalic presentation in anterior placenta. The whole abdomen sonography revealed a mild fatty liver, no ascites, and right kidney had mild hydronephrosis. Serum plasma fibrinogen was also sent. It was 180 milligram percentage, and APTT was 55.9, and D dimer was 15.45. Serum ammonia was 61. Serum bile acid 164.34, and serum HIV, IgM, dengue NS1 was negative. Malaria AG, lepto IgM negative. Blood parasite malaria not detected. Blood culture and sensitive was sent, and which showed no growth. Serum procalcitonin was also raised. It was 4.23, and the patient was blood group was B positive. The patient was diagnosed with intrauterine fetal demise at term, complicated by acute fatty liver of pregnancy with acute kidney injury and DIC. Patient was immediately shifted to the ICU and managed with multidisciplinary approach involving obstetrician, gastroenterologist, and nephrology. Blood products were arranged in view of coagulopathy. Pregnancy was terminated after counseling, and induction of labor was done with mifepristone followed by misoprostol. And patient had a vaginal delivery, which was a male fetus with a second degree perineal tear. and genetic counseling was done for fetal DNA storage. Post delivery, she developed right vaginal wall hematoma with worsening pain and swelling. Imaging revealed a large hematoma, and she underwent vaginal hematoma drainage with resuturing. She required multiple transfusions of PRBC, FFP, and cryoprecipitate. And post-operatively, she was managed in ICU with antibiotics, correction of coagulopathy, DVT prophylaxis, and close monitoring. Her clinical conditions and laboratory parameters gradually improved, and she was discharged on hemodynamically stable condition with multidisciplinary clearance. She was on in total day of 11 days. She was in the hospital. Thank you.
All right. Yeah. Thank you, Dr. Aziza. So here, my question would go to Dr. Deepak. So would you apply the Swansea criteria here, sir?
So
And which criteria?
before we go ahead now, I think we should
Yes.
summarize it. You know,
Yes.
so
Okay.
here we have a primey in her third trimester who is hypothyroid primey, who
Yes.
presented acutely with pain,
Hmm.
vomiting,
Yeah.
and had obvious icterus, deranged coagulopathy. No feature suggestive of preeclampsia like pedal edema nahi tha. BP was normal.
Yeah.
Labs showed hypoglycemia, which is a clinical marker towards what's happening. Platelets are normal, which rules out HELP. Modest transaminitis, so there's not very high transaminitis, which we see in acute, viral hepatitis. Uric acid is elevated, which is not seen in other pathologies. We have AKI, Ashwati is here. So we have AKI, that is again a very common feature, very prominent feature of AFLP. We have increased serum bile acids, which can divert a mind to intrahepatic cholestasis. But we also know that in acute fatty liver of pregnancy, we can have increased serum bile acids, and the reason we'll discuss. And then IUFDS helped the lady actually, and viral serology was negative. So this is how we can summarize it, and then the diagnosis is very obvious because we
It's
have
very
got
obvious.
acute onset, sorry. So we have got an acute
Acute
history. We
onset
have got
liver.
hypoglycemia, AKI, DIC, and looks like AFLP
Yeah.
at the outset. Right.
So I think it is fitting all the clinical features and laboratory features of Swansea criteria. I think that's this thing. So it's
Yeah,
very
Mohini.
obvious it's AFLP. So Swansea criteria is what they guide. Usually, what we these criteria we use for the diagnosis, I think. But before that, we usually rule out other diagnoses, and it is a diagnosis of exclusion. What I say, AFLP, and improvement after the delivery. It is a very prominent thing. The single marker hypoglycemia also is a very prominent feature of suggesting of AFLP.
Yeah. Okay. So as rightly pointed out by Dr. Amey, also the features which differentiate it from severe preeclampsia and HELP. So I would like to ask Dr. Ashwati as well that what other features do you look for when the transaminases and thrombocytopenia overlap? Dr. Ashwati.
So this patient presented with a very classical textbook picture. She fulfilled multiple criteria, multiple Swansea criteria for the diagnosis of AFLP. But in many cases, we don't get that. We often have an overlap of these symptoms. Close mimics of AFLP are severe preeclampsia and the HELP syndrome. However, in this particular case, see, she came with a predominance of systemic features. She had nausea, vomiting, decreased appetite, polyuria, polydipsia. There was very mild hypertension. The platelet count was normal. Severe hyperbilirubinemia. And there really weren't features of HELP or preeclampsia. Like she didn't have severe hypertension or thrombocytopenia or proteinuria. So this was, more of a straightforward case. But oftentimes, what happens is these syndromes can really overlap. For example, hypertension is something you see in 100% cases of preeclampsia. You see it in 85% cases of HELP, and 50% cases of AFLP also have hypertension. So it is not like, something you see exclusively in HELP or severe preeclampsia. It's the same thing with thrombocytopenia. However, in HELP, you have more of hemolysis. Here, I don't think there was any evidence to suggest hemolysis. Ultimately, the treatment would really not change, either of these conditions, be it severe preeclampsia or HELP or AFLP. The treatment would be expedient delivery of the fetus and maternal support.
Okay. So yes, Dr. Ahmed, then can you please throw us some light on what would be the first crucial hours when the lady is first diagnosed with AFLP? How do we go about it? What
So basically, I
manage?
think if you can pull up, do you have the slide of the Swansea criteria? Because there will be
Yes, I
residents
do have.
also, right? So you can just put that up. It's a very exhaustive criteria, 6 clinical features, 7 laboratory parameters, and 1 ultrasound, and at least 6 should be positive out of all those to call it. And I completely agree with Ashwati saying that most of these liver issues in pregnancy have some overlap with each other, and it's very difficult to differentiate where the picture is going, and at the end of the day, once as the patient clinically progresses over a period of time, then the picture becomes more and more clearer as time passes. So AFLP definitely is an emergency, and hypoglycemia is the most important feature that we see over here. And why hypoglycemia is because of low sugars, in the
Mitochondrial.
sense that LCHAT deficiency in the child, then the child is unable to metabolize the long chain fatty acids, and because of that these toxic metabolites build up. And we all know that in pregnancy there is already an immune dysregulation, and the maternal liver gets overwhelmed with all these toxic intermediate metabolites, and because of that there is a mitochondrial injury. That's important, because this is where it all starts. So mitochondrial injury causing hypoglycemia. So hypoglycemia is the most important feature here, less ATP production basically, and because of that, this needs to be corrected right up early. So two big IV lines, fluid, DNS, correct the hypoglycemia, give 25% dextrose, correct coagulation. That is also very important. These patients predominantly behave like an acute liver failure kind of a picture where the INR is pretty high. So correct all that. Do a TEG thromboelastogram if it's available, and correct coagulopathy, and expedite delivery as early as possible. Step 1, hypoglycemia. Step 2, get the coagulation through, and step 3, work up for the delivery of the baby. Because once the baby is delivered or baby dies, then obviously the LCHAT metabolism, I mean, the deficiency because of which the long chain fatty acids don't get metabolized stops. The injury stops. The mitochondrial injury stops from the maternal liver, and everything falls in place.
So in this particular patient, I can ask question, right, Rohini?
Sure,
Yes,
sure.
ma'am, of course.
Yeah. So in this particular patient, she was referred from somewhere. So probably, and she ended up in IUFD, and the disease itself progresses very fast. So if I was a primary person or the primary obstetrician, what is the red flag? They typically present in third trimester, maybe after around 34, 35 weeks. So usually baby is salvageable and very bad vomiting. I had experienced one such AFLP in my practice, and I mean, for no reason she had vomiting, and when she looked icteric. We have to do LSCS because she ruptured and it was meconium and all that stuff, and it was retrospective diagnosis that it was the AFLP. But in this particular patient, before IUFD, uh, was it possible to diagnose?
Madam, here we have hypoglycemia is the feature which differentiates
Yeah.
it from others. Actually, even acute liver failure can present this way with hypoglycemia. That is also an initial feature of acute liver failure. But here, if you see, the transaminases is very modest. It's not in thousands, like how an acute viral hepatitis presents. And also, we see a normal platelet count, so the help is out.
Typically, viral markers take a day's time or 2 days time, for the answer that for us to get. But LFT, SGOT, PT are available quickly. Bilirubin is available quickly, and hypoglycemia. So, thinking on those lines, can we initiate treatment? I mean, start action to
I
deliver
think
the baby if baby is alive.
I think deteriorating liver function test, AST, and bilirubin deteriorating, and with the coagulopathy, it is absolute. I think the decision will be same if it is a AFLP or HELP. That doesn't matter, because
Correct.
the recovery of
Correct.
mother will be
Because
possible.
anyway, even for help for preeclampsia and everywhere, the
Yes,
treatment is delivery.
almost termination of pregnancy is the this thing.
Absolutely. And we also have a slightly elevated uric acid, and probably it's the lactates that compete with urate excretion in the distal tubules, right, Ashwati? Because of
Yes,
which there is
yes,
elevated
that's
uric
true.
acid levels, and plus excessive production of uric acid because of the uh, liver metabolism also, in the sense that liver necrosis also. Isn't it,
The
Ashwati?
thing is, yes, there is also a deficiency of vasopressin because there is decreased secretion of vasopressinase by the liver. So there is decreased vasopressin, and these patients have polyuria and they're typically volume depleted by the time they present.
Right. So
So
IV
that's
fluids
another
also an issue.
contributor for the raised uric acid levels.
A red herring here could be the raised serum bile acids, but we all know since it's a mitochondrial pathology, so because of which the ATP production is less, and because of which there is because these bile acids require a transporter to be transmitted from the hepatocyte into the bile canaliculi, and because of deficiency of ATP, this transport doesn't happen, and that's why the bile acids do not come into the bile duct and they are in the blood. In the hepatocytes and the blood, they don't get excreted, and that's why you see a high serum bile acid. So that is the reason why this goes up.
So
And this
hepatocyte
should
are
not be
too much.
confused with ICP.
So hepatocyte too much exhausted to at least excrete this
Yeah.
also bile acids.
Correct. In your treatment line, you said correction of hypoglycemia by giving 25%. Usually, our labor rooms are filled only with normal saline and ringer and not really dextrose. So, how to give this 25%? I mean, it's available as emergency drug, but
I'd start with 0.9 DNS and then make it available now. So you don't have options. Or at least keep on giving glucon D, if there is no option there, because that's the fastest way by which we can build up the and avoid, because these ladies usually have vomiting, so they become they are not having any food, so they would eventually become more hypoglycemic, and that's the trigger basically that pushes them into a bad liver injury.
So, would you recommend genetic testing of the fetus or parents, Dr. Ahmed?
Yeah, absolutely, because we see that LCHAT deficiencies, that is this gene HADHA, right, Deepak? I think
LCAD, LCHAD.
So that is the
Yeah,
deficiency,
that is
and the gene which is responsible is
gene is
HADHA or
yeah,
HADHA.
HADHA.
Long chain hydroxyacyl dehydrogenase, I think.
Yes.
And so so parents should be tested genetically, because that is very important, because in terms of if you want to plan a future pregnancy, so we require them to, mother is usually heterozygous in this scenario.
Yeah.
So it has to be tested at least for next pregnancy prenatal counseling. Yes, it has to be done.
Always male fetus is there, only then the mother gets such kind of presentation?
That I'm not aware, ma'am. Is it
Male
male?
fetus is a risk factor.
Yes. I mean, I'm not sure whether it really makes a difference.
Yeah, but I mean, I think I read somewhere that male fetus is actually a risk factor for mother to manifest this. However, I think this LCHAD, right, on the whole exome sequencing, it comes positive in only 20% patients.
20, I agree. There
Yeah,
are other
and not
genes
all
also.
variations are also not pathogenic.
Absolutely.
So what is the recurrence risk now if we find that the fetus is positive? How does the counseling change? Like if the fetus is positive and negative, what is the recurrence risk? How does that depend on this? Recurrence.
Best to get a geneticist into this because at the end of the day, if there's one child is affected, the second child can also get affected if there are two heterozygous genes coming in with both the parents. So 1 in 25, 1 in 4 is what we look at, right? So
yeah. So as rightly pointed out, Dr. Ahmed, that we have to expedite the delivery, and side by side you have to correct the hypoglycemia and the coagulopathy. Now we have delivered the patient. So next, and in the postpartum period, what do we need to look for? Now the delivery has happened. We as obstetricians are relieved that at least that part has been managed. So postpartum, how does this patient respond in the postpartum, Dr. Deepak?
So first, Dr.
What do we need to look for?
The first 48 to 72 hours are very crucial because the recovery starts after that. So in that period, we need to see the hypoglycemia, hepatic failure, progression of liver enzymes, and we need to keep close monitoring in coagulopathy and encephalopathy also. So infection, sepsis also are common because already the immunity is low, and so these are the parameters what we usually see in 48 to 72 hours. Patient may deteriorate and then recover. So those 2-3 days we need to keep a watch on patient.
Right. So what happened here, Rohini, in our case is that we had this hematoma forming in the vaginal wall, right? And it was so difficult to handle all that.
Bleeding.
Just make a point that whenever there is a coagulopathy, it's better that we use pressure packs and drains judiciously. Be it a vaginal delivery, if there was a tear and a possibility of submucous hematoma, pack vagina or keep a drain. Even if it's a operative delivery, we need to take that care. Prophylactic.
We had packed it, ma'am. But again, the hemoglobin was dropping. And so we did a scan post delivery to look for the size of the hematoma. Our plan was if the size is the same, we won't be touching it.
Okay.
But the size was progressively increasing. So we had to actively get involved because the coagulation profile was also not improving despite
One
because
more thing,
collected.
can we use tranexamic acid in such cases, which we are used to use it everywhere in PPA?
We did. We are not sure how much it actually helped because of the. However, we get so much amount of cryoprecipitates and FFPs. Despite that, the hematoma was increasing in size, and again, yes, we had to drain it. Again, after resuturing, there was again hematoma formation, but this time it was not. Luckily, it was not increasing, so we kept it packed. And again, with the help of FFPs, cryoprecipitates, we just controlled it somehow.
I remember one patient who, on the second day of delivery, actually worsened and developed encephalopathy, and we had to start plasma exchange in this patient. And she improved after a few sessions of plasma exchange.
Mm-hmm.
But I think, the initial first 48 to 72 hours, like Dr. Deepak and Amey said, they are very crucial. You might have a small number of patients who actually worsen also during that time.
So we need to keep an eye on all the parameters.
So, like how Ashwati just pointed out, there is one very close mimic TTP that can come like this,
Yeah.
where you have
That
where
can
it's
be.
more like help, help kind of a
Yes.
laboratory feature where plasma action is very important because of ADAM-TS13 deficiency. So the way we differentiate is that in TTP you'll have a very low platelet count. It won't be like HELP where the platelet count is slightly on the higher side. It has a really low platelet count and very modest liver injury again. So I think that is a marker, and we'll have neurological symptoms also there. So where plasma action in rituximab, I think, right, Ashwin?
Oh, yeah, eculizumab, no?
Okay.
Ma'am, could you just elaborate as to how to keep the drain in the vagina at your episiotomy site, and for how many days do we keep that drain?
No, it's not days, it's only for few hours. It's not vaginal drain, but it should be placed in submucous or muscular plane, even if it's a perineal tear or episiotomy. So before closing the mucosa completely, place either corrugated rubber drain or a glove drain or whichever drain you are comfortable with, and allow it to ooze, because that is one thing. Second thing, whenever we are re-exploring second time, there is no point in resuturing again. Keep it open and place a pack. If the plane is open, place a pack. If you are closing mucosa, place a drain under mucosa, and the drain can come out through the skin side.
Okay.
So whenever there is coagulopathy, raised bile acids, I mean, apart from this AFLP, at times even IHC patients, we usually take this precaution of keeping a drain in the wound. Because if you don't keep the drain, there is a possibility that, and these are dead spaces, the rectovaginal area or the lateral vaginal wall, all those spaces, paravaginal spaces are, they can expand like anything with hematoma, and they can accommodate large hematoma. Nothing is seen outside, and hemoglobin starts dropping or it starts accumulating inside. And another clue is patient gets excessive pain, not as a routine episiotomy pain. So pain not responding to our routine treatment, there has to have a hematoma. So any coagulopathy, low platelet count, even if it's abdominal surgery or vaginal, it's better that we place a drain.
Oh, question then. IUFD in AFLP is it actually protective for the mother? You said, Dr. Amey. So
Yeah, looks
what
like,
are we?
isn't it? So the mother was, I would not say lucky in terms of that, because I definitely not a great thing to have, but the injury goes away when the child does not survive. The injury to the maternal liver goes away. So in general, looks like it helped the mother. But we must try and expedite the delivery as early as possible and before some such a thing eventuality happens, if the baby is mature enough in terms of its lung.
Correct. So, in a way, if IUFD happens, obstetrician doesn't have a dilemma whether to deliver or not. If it's a 34, 35 weeks fetus and you are still, dwelling, what is the diagnosis? Should I deliver? Should I wait for steroids to act? And things like that. With IUFD, probably it's easy to take decision of delivery.
So we were
that-
lucky, isn't it, Rohini? If the baby would have been alive, it would have been a difficult scenario.
No, I think with the AFLP itself, the decision would have been easy, regardless
have
of the
to deliver.
gestational age.
Particular patient had, all the parameters. I mean, all that particular criteria, everything, almost everything was positive. So there was no diagnostic dilemma. And once you diagnose AFLP, baby has to be out. That we know.
The diagnostic dilemma actually starts when the patient presents in the initial stage,
Correct.
like rising bilirubin. So what next? Is it hepatitis? Is it AFLP?
Right.
Does it need urgent delivery or conservative because it is hepatitis? That is what is a dilemma as an obstetrician.
Rohini, that's what I was wondering.
Yeah.
Primary obstetrician को क्या लगा रहे
क्या
हैं?
करना है?
Right.
So,
Then finally, when everything was failed, they referred to Apollo. I mean, it's really tough to decide at early or initial phase.
So Dr. Ashwati, are there any emerging diagnostic tools or predictable biomarkers for
So there are no validated or widely used biomarkers, and AFLP as of now remains, a clinical diagnosis only. It's with the late trimester presentation, the clinical features, the laboratory evidence that you have. In fact, probably the only thing, I mean, you have a genetic marker, that's the whole exome sequencing and the LCHAD deficiency diagnosis. So this is probably the only upstream marker that you have. But then again, this is not something you would routinely use for screening in a low risk gravida.
True. So Dr. Deepak, what is the in current scenario? What is the mortality rate these days? Because previously, during our PG days, we had seen a very high mortality.
I
And
know.
so current scenario, how is the picture now?
So now the mortality is improving. The textbook mortality is 1 to 2%. Initially, it was 10 to 20% because the initial test of LFTs we are getting late. I think now there's our threshold to do the LFTs are very low, and diagnosis also is getting picked up early. The better ICU care and everything that has helped. So it's almost 1 to 2% is a mortality rate. The maternal mortality rate I am talking about.
So yes, Suchita ma'am, then in next pregnancy, if a female have had this history of AFLP. So we as obstetricians, keeping this history in mind, how should our next pregnancy plan should be?
This particular lady has done a genetic counseling session, done exome analysis of that particular fetus, and both of them have undergone their genetic evaluation. I mean, the couple. So with that, if we know that with that thing in mind, we know that there is a possibility of recurrence up to 25%, maybe. And usually this happens in late trimester. So I think I would keep a hepatologist or these experts, one of these experts in loop right from the beginning. Avoid all possible hepatotoxic medications and do frequent SGOT, PT, ALTs, liver enzymes, maybe every time in a trimester, first and second, and after second, third trimester, maybe every 15 days. Correct me if I'm wrong. Having said all this, I don't know whether you can really prevent, but if fortunately pregnancy reaches term around 36 weeks, I may say that it's better that we deliver. And meanwhile, I'll keep in mind if the fetus is female or male. If it's a male fetus, again, I'm highly worried that the same history may repeat.
Yeah, but how can we predict whether it is a male fetus?
No, we cannot predict initially. It's a male fetus or female.
Any other inputs, Dr. Ashwati, Dr. Amer, and Dr. Deepak?
So I think for the care for the residents who are joining in elderly primary, you see deranged LFT, you see hypoglycemia, you see AKI, DIC, raised INR. Think about AFLP. This is the first thing that I think if to initially differentiate, where the train is heading, these markers really help us. And modest transaminitis. They'll not have transaminitis in thousands, what we see in viral hepatitis.
And see, what I would like to say is in practice, you have a lot of patients who are in the overlap zone. I mean, in AFLP and its close mimics, that is HELP and severe preeclampsia, you can have hypertension in all three situations. You can have acute kidney injury in all three situations. There are certain clinical markers, certain laboratory markers which can help in distinguishing between the three, but then I don't think we really waste a lot of time in ascertaining the exact etiology when the management remains the same. It is expedient delivery and maternal support.
I
Right.
just have a question, like in case of preeclampsia and HELP probably not, but preeclampsia we usually wait for steroid action to happen, especially if it's a borderline fetus, 30 to 33 weeks and so on. Does the steroid help in even AFLP patients? These are overlapping patients. I mean, initial phase, we don't know whether we know that this is not viral hepatitis, but AFLP and HELP.
I think steroid won't help because it's a
Yeah.
mitochondrial pathology.
Yeah.
What steroid might help is to mature the fetus lungs, but I think not in terms of the disease process.
Okay, so I think we'll finish with the AFLP session. And it was a good enlightening session. We have discussed the various confusions that we have as obstetricians to make the diagnosis. So few learning points. So rightly pointed out by Dr. May, a very sick patient, hypoglycemia, bad INR, and moderate, not so high SGOT, SGPT. You have to think about AFLP. And with the, yes, very high SGOT, SGPT with stable sugars, we can think about hepatitis. More predominantly, if we see hemolysis and thrombocytopenia, we have to think HELP, because high BP issues can be seen in all these conditions. And yes, ICU care, you have to correct the hypoglycemia, coagulopathy, and expedite the delivery. And postpartum period, you have to actively monitor for hemorrhage, for hypoglycemia, hepatic encephalopathy, AKI, and sepsis. And so, as rightly pointed out, Dr. Ashwati, it is more of a clinical diagnosis. There are no emerging biomarkers. Luckily, the mortality rate has come down to 1 to 5%, which was more than 50%. And in next pregnancy, obviously, we have to look at certain points that the patient should be early booked. We have to frequently monitor the liver function and glucose. And especially, we have to be vigilant in the third trimester to look for early signs, which may present as deteriorating LFTs or hypoglycemia, or even symptomatic patient present symptomatically with nausea or malaise. We have to be alert. And yes, plan admission with certain derangements, these derangements seen, and plan delivery by 37, 38 weeks in a tertiary care center. Anything else you would like to add? We can
I
add
think
here.
AFLP is mitochondrial hepatocyte injury, and
Sorry?
HELP is more of AFLP is a mitochondrial hepatocyte injury, and HELP is more of a placental-driven endothelial injury. I think this is the basic concept.
All right, so then I'll hand over the session to Dr. Krutika. Dr. Krutika, you're here?
Yeah, hi. Thank you, Dr. Rohini. If you could stop sharing, I can share my screen. We move on to the next case. We are going to discuss acute hepatitis infection in pregnancy. 26-year-old gravida 2 para 1 living one with 28 weeks of gestation. She has a previous full-term normal delivery. She's delivered 3 years back, male child, alive and well. She gives no history of any chronic liver diseases, no diabetes, no hypertension, no thyroid diseases. Her booking investigations, which was done at 12 weeks, was with hemoglobin of 10.6, CBC was 7,600. Her triple H was negative, TSH was 1.6, and fasting sugars were 82. She presents now at 28 weeks with low-grade fever, with malaise and body ache, progressed to nausea, vomiting, and anorexia. She developed jaundice with dark color urine and pale stools. She gives no history of any hepatotoxic drugs or any blood transfusion. Now, her fever has been there for the last 7 days and it has been a low grade fever. The nausea and vomiting is there since the last 6 days. She complains of lack of appetite since 1 week. The yellowish discoloration seen in the eyes and on the skin was since the last 5 days, and dark colored urine and pale stool since the last 4 days. On examination, patient looked moderately ill. There was icterus, mild pallor, no edema, no lymphadenopathy. Her pulse was 110 with BP of 110/70, and she had a temperature of 38 degrees centigrade. On examination, per abdominal examination, uterus corresponded to 28 weeks of gestation. Longitudinal lie, cephalic presentation, FH is 162 beats per minute. Her liver was palpable 2 centimeters below the costal margin, mildly tender, no splenomegaly, no ascites. On per speculum examination, cervix, vagina healthy and there was no discharge. PV, the os was closed, uneffaced and tubular. At this moment, my provisional diagnosis, what I was thinking is probably acute fatty liver in pregnancy, acute cholestasis in pregnancy, or viral hepatitis. So here we ran a few tests and these are the reports. At present, her hemoglobin was 10.2 and her leukocytes was 7,800, platelet of 1.8 lakhs. Her bili was 8.6, AST was 450, ALT 980, alkaline phosphatase 320, serum albumin of 3 grams per DL. Prothrombin time was elevated at 18 seconds, INR was 1.2. Blood urea was 28 and serum creatinine was 0.8 milligrams per DL. We ran her viral markers and she was anti-hepatitis E IgM positive. Now, hepatitis E is a non-enveloped single-stranded RNA virus from the Heptiviridae family. Now, it has 7 genotypes that have been identified, of which genotype 1 to 4 are known to affect humans. The fecal-oral route of transmission is known. It has an incubation period of 2 to 10 weeks, and vertical transmission is between 23 to 50% with a mortality of 5 to 25%. Now, having known all of this, I'm really worried, but I would like to know, why is hepatitis E so severe? Because it has a fecal-oral route of transmission like hepatitis A, but why is hepatitis E so severe? That is my question to our hepatologist, our gastroenterologist. Sir, could you please enlighten us?
Deepak?
Yeah. So hepatitis E, specifically genotype 1, which is prevalent in India, which has a more severe natural history in a pregnancy compared to hepatitis A. Hepatitis E has a somewhat different compared to hepatitis A, that it has a placental replication. So it increases viral load in placenta. Second, the Th2 immune bias is there in pregnancy. So cell-mediated immunity is somewhat, compared to the normal person, is lower in pregnancy, and which affects the viral clearance. And that's why hepatitis E is replicate very fast in the pregnancy. Third is like there is a genotype 1, which is prevalent in India, which compared to other genotypes is very much virulent. So that virulence itself plays a role. And we have seen the cytokine storm, which is developing faster in hepatitis E compared to hepatitis A, which is TNF alpha and interleukin 6 based cytokine storm. So these are the pathophysiological reasons why hepatitis E is severe. So hepatitis E is very recent. Earlier, it was only hepatitis A and B. So it is earlier called as non-hepatitis A and non-hepatitis B virus, I think. And they labeled it as hepatitis E because somewhat different with this kind of virus. So that's what they have found, that the difference in a pathophysiological stage. So the virulence is very high compared to the hepatitis A.
So it is the attenuated cellular immunity and high viral load because of its
Yes.
placental replication that makes hepatitis E far more severe. So could you please interpret these levels for us with the
So
raised
to add on, I think placenta becomes a reservoir for the
Yeah.
virus.
Yes.
And
Yes.
and because of estrogen and progesterone being on the higher side, that also
Yeah.
enhances viral
That also
replication.
enhances the
So I think,
virulence.
They are steroid hormones and they tend to increase the viral loads. Yeah. So, so how would we interpret these elevated transaminases, and what is the
So in
significance of this prolonged prothrombin, prolonged time, INR?
yeah, in this case, I think ALT is more than AST. That is a more
Yes.
prominent feature is the hepatocellular type of injury. I think the trimester is advanced trimester, so that's why alkaline phosphatase we cannot interpret directly as a cholestatic injury. We don't have a GGT level, but it looks like a hepatocellular injury. ALT is nearby to 1,000, so it is usually seen in a viral hepatitis, acute viral hepatitis, ischemic injury, and other type of injury similar to that. So it looks like a acute hepatocellular injury, and the most common reasons are acute viral hepatitis in our region. So that's how we usually see what type. And you already mentioned in a history that the drug you have ruled out any drug history hepatotoxic. So this is ruled out. INR. So in this case, at least INR is okay, but coagulopathy is a feature of acute liver failure. So we usually watch INR. How is it progressing? And it's the strongest predictor of mortality. So that's we need to keep a watch. And which patients are
Do you suggest in all such patients who have, bilirubin raised or we are suspecting liver injury, should we be doing GGT and other tests as well?
not a GGT we can do, but if it is a doubt of having a cholestatic injury associated with the if it is not obvious, it is not a hepatocellular injury, then go for GGT or at least sonography to see any biliary tract obstruction, because gallbladder stone and CBD calculi are also very common in and the AST/ALT also elevated in those reasons. So we usually do the sonography or GGT. GGT will give early idea that bile injury is involved. Drug-induced liver, I already told you that drug-induced liver injury has subtle sign. The sonography will be normal, GGT will be high.
Lady was having fever for 7-8 days.
Yeah.
So it's not possible that she was taking paracetamol every day and that can cause injury?
No, because the fever set up earlier, so we see the pathology is already there, and paracetamol and the toxic dose. I think it's very high. So we are not commonly seeing the paracetamol poisoning. Yeah.
Got it.
So if you look at history again, you go summarize it. It's a gravidate 2 third trimester subacute onset. So there's a time gap. There's time gap between the onset of illness and jaundice. So there's at least 7 days where there was a prodrome. Then jaundice came in. There was no itching absolutely. BP was normal. Platelets were normal. And you have a very high SGOT, SGPT. We all know that SGOT comes from both cytosol and mitochondrium, and SGPT comes only from cytosol. So there are certain LFT. The way we interpret them is that if we see so high derangement of SGOT and SGPT, the differentials become very few. One is Deepak, I'm sure Deepak would agree. Acute viral hepatitis is one where SGPT is more than OT. You have got then the second one is ischemic hepatitis, where we see drug can present anyhow. It can present isolated high bilirubin. It can present SGOT more than between thousands and hundreds. DD can present anyhow, as what Dr. Deepak mentioned in his presentation. Few other differentials also include acute Budd-Chiari, acute Wilson's, acute fulminant autoimmune hepatitis, acute obstruction of the biliary tract. These are the only places where you see such high enzymes in thousands. Apart from that, you don't see enzymes in thousands in other pathologies of the liver. So that's a marker pointing towards the viral hepatitis. The prodrome, the distance between the onset of symptom and the clinical onset of jaundice, and the other parameters that helped us to diagnose it in terms of clinical and biochemistry.
So when should I repeat the INR again?
So
if the INR is elevated, then every 12 hourly.
Okay. So the predictors of severe disease, of course, would be now the elevated PT and the INR, rising INR. Ma'am?
And the altered sensorium also is a predictor of disease. It's a part of acute liver failure. So hypoglycemia, altered sensorium, and because these are the severe.
Ashwati ma'am, is acute kidney injury common in these patients?
Or rather renal complications? Is she
I think
there?
Ashwati is left. No, Ashwati just left, I think, some time back. I think.
Sir, if you could highlight.
Yeah, I think the 15 to 30%. I think the AKI hepatitis E patient have 15 to 30% of probability of AKI development. It is have a aggressive fulminant course. That's why the first organ involved is apart from the liver is a kidney, and other followed it. So that's how the organ failure develops in acute liver failure associated multi-organ failure. So
So it is the
it leads to
glomerulonephritis by the virus that causes. I
yeah,
think glomerular
glomerular
injury
virus.
that causes.
Yeah, and in acute liver failure, the HRS also setups is a type of HRS that setup is.
So is there any antiviral therapy now for hepatitis E infection?
In pregnancy, I think it is ribavirin. I think that is not used in pregnancy. Interferon also cannot be used. So it's not in pregnancy. It is not. The supportive therapy is the only therapy what we usually go with. In acetylcysteine, I think it is useful. Means what we are using. Theoretically, non-paracetamol poisoning also in acetylcysteine has a role of antioxidant. It decreases the oxidative stress, increase the microcirculation in liver. So it helps in prolonging delaying this thing, progressing the disease. That's why.
And it would be relatively safe in pregnancy to use it compared to
Yeah. N-acetylcysteine is very safe.
So ribavirin as a drug, it is used only in chronic hepatitis C virus infections, usually in genotype 3, where the immunosuppressed patients get it. So solid organ transplants, bone marrow transplants, they would have more of a chronic HEV. And we have also seen chronic HEV progressing to cirrhosis in immunocompromised. And genotype 3 usually not in India. Genotype 1 and 2 is in India. And N-acetylcysteine replaces glutathione, so improves the
oxidative stress.
Correct. And also the mitochondrial injury to the. So ribavirin is a teratogenic drug, so not to be given in pregnancy.
So what would be the signs for a fulminant hepatic failure in this case?
Or rather, she is 28 weekers and we have diagnosed her as hepatitis E. So how should we monitor this particular patient? Should we deliver? What is the indication for delivery from your point of view?
So delivery, in this case, I mean, delivery will not help to improve the patient. So you have to see the appropriate condition of the mother, treat it supportively. We cannot compare it to the AFLP and HELP syndrome. The severity of disease doesn't decrease down after the delivery. So just manage the patient. Sometimes during pregnancy also liver transplant has been done. The cases are like that. I think Dr. Amaya will be aware of that. I think hepatitis E, fulminant acute hepatitis E, liver transplant is indicated if it is is deteriorating the patient. So that's what delivery. We don't think about the delivery or termination of pregnancy, just to improve the patient or something.
So there are two parameters basically: the INR, that is the coagulopathy that tells us, which is the single listing criteria for a liver transplantation is an INR above 6.5. So that means INR is one very important factor that should be considered in terms of how bad the liver is behaving, because liver doesn't make prothrombin because of the hepatocellular necrosis, and that's why the INR goes up. And second thing is the hypoglycemia that sets in, which tells us that there is an acute liver failure that is imminent. So the idea is to deliver the child quickly, and if the hepatocyte injury is persistent, there is cerebral edema, the INR goes up, patient is encephalopathic, intubated, then we can think about liver transplant. But in a pregnant status liver transplant, we should first deliver the child, and then if at all the hepatic injury is prolonged or the ALF persists, then only think about. But usually hepatitis A and E are all hyperacute illnesses, and we have got patients who 85% of them would just come out because they are hyperacute in presentation, not the subacute varieties that we see in hepatitis B where a liver transplant may be required. So usually 85% may go away with the transplants just by plasmapheresis.
Hepatitis A is very self-limiting, and that way, may not cause much of a distress in pregnancy, and hepatitis E is very bad to deal. Is it so, or am I wrong? I'm wrong?
So Hep A per se is also bad. It causes stillbirths, it causes IUGR, probably stillbirths more, preterms. But Hep B is more bad in terms of maternal and fetal outcomes, including deaths also, that we all are aware, 10 to 30% chance of.
Equally bad in non-pregnant state, hepatitis E.
Not that bad
Not
as
that
compared
much.
to pregnant states.
So, sir, according to you, we have to monitor this patient in terms of how her liver is behaving, and depending on that parameters, we need to deliver the patient, right?
तो क्लिनिकली मैडम आज की मतलब ड्राउजी तो नहीं हो रही है ना, ज्यादा सो तो नहीं रही है ना, दैट इज फर्स्ट cerebral edema, encephalopathy, and second is look at the INR. Transaminitis may not matter, it can go high, it can go low.
Yeah.
The amount, the elevation of transaminitis does not indicate the severity of the liver illness. It is how there is INR gets elevated and encephalopathy that indicates how the patient would behave.
So at the time of diagnosis,
Sometime.
INR is normal. How frequently should we repeat it?
So every day, if the INR is normal, if the INR is deranged, then every 12 hourly. If it's about 2 and 3, then every 6 hourly.
And if it's normal, then?
Every day, once a day, till the transaminitis go below 1000.
Oh, okay.
Okay. So if we have a patient now with a normal INR and elevated PT, we still wait. We give 24 hours, we repeat. If the patient is conscious and oriented, we still wait. So I think it's one day at a time, and we can, as much as we can, pull on this pregnancy. And ma'am, what do you suggest should be the route? Now our patient is deteriorating. She has an elevated PT, but she's still not disoriented, and we want to deliver this patient quickly. Would you choose a vaginal delivery or a cesarean? And if so, would a cesarean section cause any issues with the hepatitis later on? In terms of healing, or in terms of would there be any issues with that, or a mode of delivery would not make a difference?
So probably, I think if you can save the baby, it's advanced pregnancy, I might as well do C-section to, how urgently the delivery is needed. And in case of operative delivery with deranged PNR, INR, we need to be, loading this patient with all kind of coagulants and in accordance with what our hepatologists and hematologists are telling us. And as I have mentioned earlier, whenever you are delivering a patient with coagulopathy, we need to have a drain in peritoneal cavity, in abdominal wall. So generously, we have to use drains. Transfuse these patients with all coagulation factors and plasma and things like that.
So here the termination of pregnancy is just for the fetus. It is not going to improve the state like in fatty liver of pregnancy. It's not going to improve the maternal state. Here it is purely for fetal well-being that the delivery must be conducted. Okay. How should be the fluid management in this patient? So I'll split this question into two. Just hepatitis E in pregnancy with elevated PT, and hepatitis E now proceeding towards fulminant hepatic failure. So before the failure, if the patient is just elevated levels, what should be the fluid management here? And in a severe case, how should it be? Because now if she has deranged, altered sensorium, she already has edema. So how should we manage the fluid here? And is oxytocin, can we use oxytocin here to augment?
I'm not aware of oxytocin, but we need to see the renal function first. As a fulminant hepatic failure, we need to see the renal functions. If output is decreased or there is a positive intake, then we need to restrict the fluid sometime, and we need to give a substance like albumin just to recover the HRS if it is ALF induced HRS, and that's what is a fluid management based on. It should be monitored. Intensivist will be helpful in those things to monitor this thing, CVP and IVC, just to make sure the fluid management will be better, and patient should not go into the fluid overload, and that will be a next problem for that patient.
Rohini, is it possible for you to contact Dr. Ashwiti, and if she could give us 10 minutes of her time to come back to the panel?
I think oxytocin, I also, Dr. Amay, you know about the oxytocin, because I don't think
we can give oxytocin. I think it's not
oxytocin,
contraindicated.
not contraindicated.
I think what needs to be seen is the urine output and how the clinical status of the patient
Clinical
is.
status of the patient.
There are no creps, how thirsty the patient feels, So just go by the clinical parameters. I think keep an ISO balance and just positive 500 to 1000. I think that's sufficient when
Yeah,
the patient is
that's
eating well. Obviously, when the
yeah.
patient is intubated, then you slightly need to slightly jack up the fluids a bit because,
Yes.
yeah, but otherwise it's predominantly clinical judgment.
Yes.
And if in the ICU, as Dr. Deepak rightly said, the IVC monitoring can help to better be the B lines in the ultrasound of the
Yes.
can help us to find differentiate between fluid overload and a normal volumic state.
So it's just going to be a repetition, but how do we diagnose a hepatorenal syndrome in this case?
So hepatorenal, we use this terminology only in cirrhosis of liver, where there is an injury to the kidney also because of cirrhosis. In ALFs, we do not use HRS per se, as we use more of an acute kidney injury or an AKI. That's what we use. Uh, uh, so it's HRS is more of a CLD related complication and not ALF related issue.
Yes.
In ALF, it's AKI.
So what should be the diet of this patient? Now, we are going back. She is still 28 weeker and oriented. And what kind of a diet should this patient consume now?
It should be high calorie, what we call the 35 kilocalorie per kg per day. At least we have to see the calories should be enough. Proteins also should be high. Protein requirement in this stage usually increases. That's why protein requirement should be high. That will be 1.2 to 1.5 gram per kg per day. That will minimum requirement, and that's what is a calorie and protein requirement in this patient in ICU.
I agree.
So early deterioration signs, elevated levels. When could the patient need an ICU? Does just altered sensorium advocate to an ICU admission here?
Surely, ultrasensorium is a encephalopathy development, so we need to calculate the future. So patient will need immediate monitoring and this thing. That's for the monitoring we can keep in an ICU. What I think.
Yeah.
So altered sensorium is Deepak's and ICU, and my nights are fired.
Yeah.
The
So
ammonia goes up.
just
That means it's all done and dusted for us.
So what should we do? How should we manage this patient if she comes with elevated SGOT, SGPT levels, but she is asymptomatic? Her only complaint was थोड़ा सा nausea हो रहा है, vomiting हो रहा है, थोड़ा सा पेट में दुख रहा है. Now she's having upper right central pain. She's having that epigastric pain, and we have done the LFTs, and these are the reports. In any
If the patient is
in this
asymptomatic, just monitor the LFTs, monitor the INR,
Yeah.
look for any clinical sign of
Yes.
deterioration, and eventually everything settles down over a period of 1 to 2 weeks.
Yes.
So, and jaundice what we see typically is that the bilirubin climbs and transaminases fall, and the bilirubin further climbs, and then it all settles down over a period of time. So, up to around 1 month is the bilirubin also almost returns back to normal. SGOT falls faster than SGPT. SGOT half life is lesser. So, we find faster fall in SGOT as compared to the
Yeah. So
SGPT
monitoring of
levels
SGOT.
because of its lesser half life.
And
then
there are some non-hepatitis viruses, dengue and those things also has to be suspected in some cases. We have a fever and other symptoms with that. If asymptomatic, we should monitor it.
We have CMV, EBV, HSV, these can present the
Yeah,
symptom.
those presently.
So what would be, this goes for all, if you could give one preventive measure to the public, for what would it be for these patients, for any patient? How
Sanitation, I think public sanitation and hygiene should be maintained. And now the hepatitis E vaccines are available. Those are not this thing eligible in the pregnancy, but before pregnancy, if you are planning pregnancy, hepatitis E virus, the vaccine will be better choice, I think.
is that vaccine available here?
Yeah, it's available now, I think.
So we just released around
And
2 months back. It's a Chinese
And-
vaccine, isn't it?
so we
Is it a
we
single
do have doubt of.
What is
at present, it is only for patients who are immunocompromised, CLD or
Yes.
travelers, who are traveling to endemic areas. So it's like similar to hepatitis B vaccine, 0, 1, 6, so 3 doses. 10,000 rupees is the cost of the vaccine for one dose. And but it is at present only recommended for those patients who are having an
Immunocompromised
immunocompromised
patients.
state or chronic liver disease, because we know that HEPI in a CLD patient is a more difficult thing in terms of it can precipitate an acute and chronic liver failure. So I think that's where it's currently indicated.
I think improved sanitation is responsibility of corporations and government. They might as well take up the responsibility.
Probably, madam, control the urge to eat outside food in a pregnant state. So it's like,
That education starts
and
from
chatpata khana.
So what about
You make whatever you want to make at home, you make. Don't you go outside and eat, especially in unhygienic places. We don't have any control on the flies, ma'am. And even if it's a hygienic place, if the fly sits on some shit and then goes, that's how the fecal root spreads. So we have no control on the flies, especially in monsoons. We have seen that.
So what about hepatitis A vaccine? Would you recommend taking it in pregnancy?
In pregnancy, I don't think so.
Before.
2
doses, 6 to 12 weeks apart.
Even if she's supposed traveling to an endemic area, would you still not recommend it?
So in India, madam, most of us
pregnancy.
have a previous exposure, isn't it, Deepak? Most of it, if we do an HIV IgG, like 70% of us will be positive. So you do a titer, HIV IgG, not IgM. And if the HIV IgG is negative, then all of us can take. But most of us eat healthy, safe food. So I think it's only on those borderline people we can vaccinate them, or travelers probably. What do you think, Deepak?
Yes, it's same. In pregnancy, it is not recommended, but anyways.
So these are some of the papers with hepatitis A and E in pregnancy. It's if the delegates would like to have a read, you can take a screenshot. These are some very good papers. One of them is a review article, and you could have a read for that. I thank you all. I would end this discussion. I'll just give you a minute. I'll just go through the chat box. Yeah, so the diet was one of the questions for hepatitis E, diet in jaundice patients with hepatitis E. So that has been asked. Sir, any pointers that you would like to give now before we end the session?
I think we have summed it up very well, isn't it? The differentiating features between acute viral hepatitis in pregnancy versus HELP versus AFLP. And I think whatever discussion has come out very well, and things are very clear how to go ahead with the diagnosis and treatment.
Yeah, thank you for making all these things so clear to us. And they look very easy.
Yeah, ma'am.
Both were speaking.
Yeah, I would like to, Dr. Bindu here, so I'm speaking from the OT. So though I could hear almost everything, it was a very enlightening session. Thank you, Dr. Amay. Thank you, Dr. Deepak. And thank you, ma'am, for moderating it so wonderfully as usual. And I would like to thank Rohini and Dr. Kritika and Aziza also for presenting such cases and carrying forward the discussion. Thank you very much. Thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you. Thank you.